everyone. Welcome to this webinar. I can't wait to talk about this topic. But before we get to the topic, I want to tell you who's going to be talking to you. You guys know me most likely. I'm Craig Escudé. I'm a family physician. Spent the majority of my career providing health care for people with intellectual and developmental disabilities, and learned a lot of things the hard way. And now I have the opportunity, very thankful to have the opportunity to share some of the things that I've learned the hard way with others, and all in an effort to improve health and wellness and health outcomes for people with intellectual and developmental disabilities. I'll point you, the only thing I'll point you to on the slide is the IDD Health Matters podcast. Please take a look at it on your favorite podcast platform, including the video version, which is on YouTube. And now I'm going to introduce to you our guests today, Dr. Jennifer LeComte. She is a graduate of the Philadelphia College of Osteopathic Medicine and has completed a Med-Peds residency and is double board certified in internal medicine and pediatrics. She was the pediatric chief resident, also founded the Center for Special Healthcare Needs. She's an associate professor at Rowan Virtua School of Medicine, both in internal medicine and pediatrics, the medical director at Rowan Virtua Risen Center, and I'll let her tell you about that, and a principal investigator on many grants. And our second guest today is Dr. Wendy Aita. She's the co-director of behavioral health at Rowan University for the Risen Center. She is a Ph.D. clinical psychologist and is a licensed psychologist in New Jersey, also an associate professor at Rowan Virtua School of Medicine, and the co-founder of the Risen Center. Again, you're going to hear about that in just a second. She's also an expert in trauma-informed care and complex medical trauma, and the clinical director of the Strong Minds program with the New Jersey Special Olympics. Now, if they don't have the qualifications, I don't know who does. So I just want to welcome both of you. Thank you so much. And we're going to get started, like I usually do, with a quote from Dr. LeComte. So Jennifer, would you tell us, when you said this on a podcast recording, which will come out soon, you said routine preventative care, health care isn't an emergency, it's always an opportunity. Please expound upon that.
Yes. Thanks, Craig, for having us. We always love talking to you and your audience. So when we founded Risen Center, largely what we were concerned about was our patient population, the people that we care about with intellectual and developmental disabilities and people with physical disabilities. They didn't have access to routine preventative health care. The problem was that they often ended up going to emergency rooms or getting sedated for access for these really checkbox opportunities to just close a gap, but didn't actually think about how do we think about the person and center the person. So the mission of Risen Center is really for a marginalized patient population. How do we get them better access? And not go to the quick fix of sedation or just say that we're not going to do it because that's not a higher priority. And what we think and what the foundation of Risen Center is, it's founded on preventative healthcare and lifestyle matters. So food is medicine, movement is medicine, and prevention is medicine, but we need to make sure that we don't send people to the emergency room to get that care, right? Dental care, they go to the emergency room. So women's health, people show up in the emergency room to get care. And we said we have to stop doing that.
Yeah, that's excellent. And, we know that people with IDD often utilize the emergency room for what would be considered more routine type problems many times. And there are certainly better ways to deliver healthcare than in an emergency setting, if it's not an emergency, for sure. So thanks for explaining that. Now let's go on to the first slide and talk about the disparities. You already touched on that just a little bit. We know that there are disparities, health disparities for people with intellectual and developmental disabilities, and certainly there are some specific to women.
So the reason why we thought that access to routine preventative care routine preventative care was such a high priority is because our patients weren't getting it. And we know that we can reduce morbidity and mortality. What does that mean? We can make sure that our folks die less often and less soon, and that they don't have complications from things that really just needed touches before it got to really a loss of life or a loss of function because they didn't have access. Part of the beauty of what Risen Center has done and why Dr. Aita is such a strong component of our access is the trauma that our patients experience in accessing some of these things through emergency things, instead of actually giving them the time and grace of getting a pap smear when they're ready to receive one, getting a mammogram when they understand what is coming, giving them the voice to say, stop, because I'm not ready. And none of those things were done, so we just say, well, we shouldn't do them, right? So we shouldn't do a cervical cancer screening or a pap smear. We shouldn't do a mammogram. And that's not the answer. It just needs more time and space in order to get people ready for one.
Absolutely. Dr. Aita, would you like to add anything?
Yeah, I think, one of the biggest things that Dr. LeComte mentioned was the increased morbidity and mortality. And our patients really have this as a preventative. If we can get the screenings, we're not doing that. When we look at even breast cancer rates in individuals with cerebral palsy, they have 3 times the mortality from breast cancer, mainly because they're not getting these screenings done. And, yes, these things are not always an emergency, and proper preparation and bringing the patient as the center is so important. And by doing that, and really the number one thing that helps people with IDD get their preventative screenings is proper preparation and good primary care. Those are the 2 things. And, if we can decrease this healthcare disparity and make sure we're getting these screenings more often, we're going to be able to prevent a lot of further damage and a lot of disparities.
Those are excellent points, and just to add to that, there are so many situations where we see people suffering needlessly or dying early from things that can be prevented. That is, our biggest concern here at Intellectability. That's why we do what we do, to help people recognize conditions that people are experiencing that they don't need to experience, that they can be treated if they were caught earlier or not have to end up in the hospital. So prevention is huge, and it's so important. And I'm going to throw in this too, there was a time where the mindset was, well, people with IDD, they don't live long enough to worry about these types of things. And that needs to not be in our minds anymore. People with intellectual and developmental disabilities are living longer, and they deserve the same preventive care as everyone else. So now, with that being said, there are sometimes some barriers to getting good care. So there are a few different types of barriers. Let's start with patient barriers.
Yeah, patient barriers are rather significant and really come in a lot of different ways. Fear and anxiety about what's going to happen is one of the biggest barriers. When I want to know what's going to happen when I go to the doctor, I ask a friend or I Google it, right? I find a way of figuring out what's going to happen. Our individuals don't often have that as their way of knowing what's going to happen. So they may be coming in and not have any idea what's going to happen or have misperceptions of what's going to happen. And we're talking about a very sensitive test in areas of the body that we've told them over and over again are private and we shouldn't let people see them. And that touching those areas may sometimes, because of some of our myths and misperceptions, we might be telling them that it's bad, or we develop a fear-based feeling about sexuality, that if somebody does something like this to you, that's wrong and you need to let us know. So there's an awful lot that comes in when we're talking about this type of a sensitive exam. So we have fear and anxiety, not knowing what's going to happen, not being able to predict what's going to happen, Previous trauma may get in the way. You know, people who may have been sexually abused, and we know that unfortunately within this marginalized patient population, sexual abuse can be much higher than in a neurotypical population for a whole host of reasons. And having this exam not only may be trauma provoking, but also may be the only way that we know that somebody's been sexually abused, especially if they don't use words to communicate. You know, not knowing why they should be having this exam, and then not knowing that they can say no. And, you know, Dr. LeComte said, you know, preventative care isn't an emergency, and sometimes this is an emergency, and we need to give them the space and the grace to be ready for having these exams.
Great points. And hang on, everyone. We're going to get to some ways to help lessen these barriers later in a little bit. So hang on. But let's talk. Yeah, but let's talk about supporter level barriers. That's us sometimes, right? Sometimes we're the problem.
So actually, we see this often, and this is we'll talk more about some of our academic societies and how they're encouraging us to either be more proactive or how they may have not helped us as physicians get to where we know. So supporters, our families, our group home providers, our just friends saying, I didn't like it, and you shouldn't go and get this done either. For sure, sexuality is a really important growth for a human. And sexuality means having personal relationships, not necessarily having sexual intercourse, but just having some intimacy and having someone be considered a friend or someone that you can talk to about some challenging things. So that's the beginning of having the dialogue. And so sometimes even those relationships aren't encouraged by some families, by some, you know, some of our faith organizations, things like that, just not perceiving that those relationships matter. And then when we have those misassumptions or when we have those thoughts, then we don't think about including everyone in access to reproductive health care. So really, it's a continuum of the dialogue, and that's why the actual doing the pap smear or doing the reproductive health exam, that's just along the continuum of how we have to have a dialogue, and we have to make sure that we bring supporters along with that. One of the biggest barriers that supporters don't allow patients to talk to their doctors themselves by themselves. And so that's also a problem that providers don't think about, asking supporters to leave the room so we can have these relationships, to have more difficult or more sensitive conversations that are private but not secret, recognizing that language too, that if we're going to assess for abuse and neglect, again, along a continuum, it may not be all the way to the point of physical sexual abuse, but anywhere in between, that we have to have some alone time with our patients who have intellectual and developmental and physical disabilities, that while they have supporters, they still deserve private time with their doctor, and we need to create space for that. I think pediatricians do this well as they understand people aging out, or, you know, as they enter into adolescence. But if they enter into adolescence and have a disability or intellectual disability, we may have skipped that part. So they didn't learn it early enough. Certainly we talk about it in IEPs, where we make sure that our patients are sitting at the table by age 14, but the doctors don't have those same recommendations, right? Or those same guidelines. So we need to make sure that we're having our patients have time with their doctors without their supporters, so that they can articulate or they can explain to us what things they're concerned about, what things they're worried about earlier rather than later. For sure, we want to do this in adolescence before we wait until they're an adult.
Great points.
And the other thing I was going to say is one of the barriers for supporters is the idea that our individuals are perpetual children. And that they aren't sexual beings, and therefore they don't need to have these exams, or that the exams in and of themselves are trauma-based and going to traumatize the individuals. And what we know is that, our individuals, individuals with mild or moderate intellectual disability, about 70% of them are sexually active. So they are having sex, and they are sexual beings, and they want to have sex, and they need to know about privacy and consent and about protecting themselves, all of those things. And if we don't give them the opportunity because we just assume that they're not cognitively capable of talking about these things, or they're never going to have sex, then we are, keeping them from having, opportunities for their own healthcare and for relationships too.
Yeah, having sexual urges is a normal part of being a human, and more than likely, people will find a way to act on it. So why not take every opportunity to provide the education at the level that's best for that person, so that they have a better understanding of it and can have an opportunity to make better choices and decisions for it. So yeah, great things there. Provider level barriers.
So
Take it away.
we started to talk about those already, because
I jumped the gun, sorry.
Well, and you can't talk about a reproductive health exam without including providers, but quite frankly, our academic organizations, or our the AMA per se, they don't actually talk about making sure that we have specific education in our med schools and our health environments to get people prepared for working with people with disabilities. So just starting there is a barrier. Really, even just talking about nutrition, we don't have those basic tools in our med schools, right? So if we don't begin talking about just interacting with people with disabilities, I will tell you, trying to get an IRB approval when you talk about people with intellectual disabilities and sex, people don't want to talk about that. So even in our basic understanding of research, so I can't even give you really good data on prevalence of cervical cancer or cervical cancer screenings, because just getting the studies at the provider level or at the systems level, and we'll talk about systems too. So if we don't do that in med schools, we're going to have very limited knowledge of how to provide care for people with disabilities. So that's where Risen Center has really started with the Rowan Virtual School of Osteopathic Medicine, where we bring students, we bring residents in to get exposure to working with people with different abilities, to overcome just that first barrier of just working with people with disabilities. Then when we talk about more sensitive exams, we can actually say, of course we would include those humans, because all humans need that, right? And so just having people have some interactions, but definitely we have some pretty significant assumptions about sexual activity, not just from the caregivers, but also from our providers. And then I think that sometimes people in healthcare kind of prioritize people's needs, right? Well, if you have a genetic condition that has a heart problem, that has to be higher priority. And the reality is, and I really love the geriatrics model, what matters, and asking the patients about what matters, which a lot of them will say their relationships and having sexual relationships, that might actually matter more, but providers don't ask what matters, right? So if we don't know what the priorities, we get it wrong. And we have definitely some very good studies that show that patient priorities and provider priorities, they don't match. And if we don't ask, we won't be able to align them.
Yep, you made so many good points there, and certainly, we all know that education is key to improving a lot of these disparities that we see in health. I kind of use the example all the time. I'm a family physician, but if you came to see me for a cataract surgery and expected me to do it, you'd probably go blind, because I'm not trained to do that. And we need training, and it is so important that we train all healthcare providers in every aspect of healthcare to be able to meet the needs of a very significant number of people, and those are people with intellectual and developmental disabilities. So great points there. System level barriers.
So this is where some of our patients truly just can't get in the door.
Yeah.
So if you use a wheelchair or some other assistive device that needs to get you into a building, even after 30 years of ADA requirements, some of our patients truly just can't get in the door. And adaptive equipment for just getting a weight for some of our patients, which we know is a big healthcare crisis, let's call it a crisis, for obesity for all humans that are in, for all access to just better foods. But if you can't get a weight, or if we're worried about even low weight. So for Risen Center, we made it a priority for getting adjustable tables so that our patients can get themselves on the table, or if they need support, we ask about it. And we make sure that we can help them on the table. We have ceiling lifts that can weigh people and can get people on tables. There are some of our patients who've never been examined with their clothes off because, again, there's been some barriers, largely because we don't know if we can get them out of their chair. Access to mammograms, you need to stand in order to get a mammogram. And to be honest, if you didn't actually have to do that test, maybe you didn't know that, right? Maybe you didn't know that you actually have to stand. I know that it seems silly and you think that all doctors know that, but if you actually never had to walk into the room, I don't know that you would know that. So people in wheelchairs, actually, part of the reason why we see them getting less access is because we don't have the adaptable equipment in our systems to get people access. And quite frankly, then it takes yet another phone call that our patients are already making, multiple phone calls to make sure that they can get insurance to cover it, that they can get more time, that they can have the right access points, and is it going to be covered? So insurance coverage is one of our biggest barriers because a lot of our patients do require Medicaid, which is a state-based insurance. And so we live in the tri-state area, so we have access to Pennsylvania, Delaware, and New Jersey, and you can't cross a line with Medicaid for our patients who might have literally a closer access point, but it's across the state line. And so that's a really big systems barrier. And certainly in our current climate, but I think it's always one of those opportunities that appear to be at risk, is that access to insurance.
So Wendy, did you have?
Oh yeah, I was just going to say, I was thinking how system level barriers become personal or patient level barriers, right? Because when somebody is worried whether they're going to be able to get onto the table, if somebody is worried if there's going to be a barrier for them getting in the door, or the ability for their provider to be able to talk to them using their assistive technology equipment, they're going to not want to come in. So this becomes a barrier because of anxiety and because of, just avoidance of the situation, because there are these barriers in place. So they become interactive and interconnected.
Yeah, that's a good point. They intersect. So, all right. So we've talked about the difficulties and the challenges. Now let's talk about what can we do? What can we do to mitigate some of these barriers and improve access and improve overall outcomes and screening?
So the first thing is just educating our patients to be their own self-advocates. So we've been privileged to create some accessible, easy to understand materials, both about cervical cancer screenings, but also about just advocating for yourself, getting some time in front of the doctor. We were able to create some documents that you can all look up, what every woman should know. And if I could just talk about language here, we speak specifically about women and reproductive health, but we recognize that people who were born female at birth don't always identify, but they still need access to this type of care. And so we were, I hope people in the audience recognize that we're sensitive to that language. We have some information in the tools that we were able to create, and we equally use the model "nothing about us without us." So asking people with different abilities how they need to receive this information. We found that concrete tools, like using a actual model of the pelvis for looking at the cervix and having our patients see what that is, touching our models, was really helpful for them to understand, but also recognize that we need to provide that information in multiple ways. We need videos. We need them to come with their moms and see how moms experience an exam. And we do this all the time in pediatrics, I think, really well. Oh, we're going to look in mom's ear. Let's look in your ear now. We have to do that for reproductive health exams too, but it needs to be, again, easy and accessible to understand. And we need to get the feedback from patients with different abilities to really make sure that we're getting it right. And we don't always include them in that, but in the materials that we created, we made sure that we did that.
So, Wendy, I don't know what you're going to say, but I really want you to touch on the bullet point number 3, that term. PAP camp.
PAP camps. Yeah. So we were very fortunate to receive some grant funding that allowed us to create some of these materials. So within New Jersey, there was the Inclusive Healthy Communities program, which helped us to get the What Every Woman Should Know booklet. But PAP camp was through a WITH Foundation grant. And what we wanted to do is, not only after getting from our focus groups some ideas from individuals on what they would like, we wanted to provide accessible materials and a program that was kind of fun. And you get a swag bag when you leave, which, you know, everybody seems to enjoy as well. But really, we wanted to put the patient at the center for a number of different things. The first is to understand what happens during the exam, and we utilize a model and we utilize a speculum, and the patient can actually do an exam on the model themselves, so they can hear what the speculum sounds like when it clicks, because it's plastic. And they know what to experience with that, and they know exactly what's going to happen from step to step to step. We identify a stop signal so they can tell the physician who is doing the exam or the provider, hey, I need to stop. And that could be a hand signal, could be a verbal signal, it could be shaking your foot, any of those things, because not only should everybody ask permission before they want to touch you, and that includes your physician, but we should be asking for permission at each step along the way. And at each step along the way, you have the ability to say no, or I'm not ready, or I need a minute. And when we have individuals that we've taught to acquiesce and say yes through some of our treatments when they're young, we need to be able to give them that voice to be able to say no. And then PAP Camp addresses ways of calming your mind, calming your body, addressing sensory challenges, and to create a personalized plan that then gets written down so that not only the patient can advocate for herself, but for us, we keep it within the chart so that all providers can see what that plan is, and they will know, you know, what to encourage. They make a list of what they're going to bring. And so for some people, it is, you know, I want to have the lights turned down a little bit. I want a weighted blanket on. I want the doctor to tell me what's going to happen. This is the support person I want to be in the room or not in the room. I want to do this by myself. And here's my stop signal, and everybody knows. And what we found is that by giving women not only the voice, but the preparation, they are much more likely to actually get the exam done, and getting it done without sedation.
Yeah, and you know, the last point there, you have consider offering some sort of medicine to help people relax, and that's not the same thing as let's knock people out to have this. I think it's very appropriate because, you know, how many of us have maybe gotten nervous about flying? So you want something that just take the edge off, you know? So again, not saying we need to have people completely sedated for an exam like that, but that might be an option to consider here and there as well.
Yeah.
Exactly.
Yep. So let's see. Here we are, strategies for mitigating barriers, patient-centered approaches continued. We've got a couple more to talk about.
Yeah, so we've we've said often, and you just led into that, that not always jumping to sedation when we're thinking about offering these services. However, there are some times when our patients are already getting sedated for some other things, like a dental exam. That's what we find maybe that more often. MRI is probably number 2, that our patients do need access to these services. They need them more imminently, or at least on a regular scheduled basis. And if they're going to get sedated, thinking about making sure that we can close other gaps during that sedation and not sedating multiple times. So we've developed some partnerships. Being an affiliate of Virtua, it's been helpful in a hospital system, especially when you're an ambulatory doctor, to say, where do we have resources that we're already sedating our patients that we can still consider closing gaps in other ways, like getting a reproductive health exam at the same time. So, and then the other good news is that we are developing some other less invasive ways to get it. We'll talk about that, but truly considering pairing those procedures together, and having relationships with multiple specialists so that we can not miss opportunities that would help us not have to use multiple sedation events.
And looking at some other options, like you said, I think you said we're going to touch a little bit more on that too. So I'm gonna save that. I won't steal your thunder on that.
Well, we're really excited about that one. It might be the next slide.
Okay. So provider and staff training and the CARES manual. We've talked about this before, and I think it's a great thing to share with everyone.
Yeah, so we hope everyone will access it. This is a way for everyone to get a copy of this tool. A couple of reasons why we really love this tool. It's for both patients to see that they can be their own advocate and ask for the things that they need through this tool. So it's about how do you create, how do you maybe ask for an early appointment? How do you make sure you ask for a longer appointment? But then it's also for staff and physicians to look at it and say, oh, wow, maybe I should offer them an earlier appointment. Maybe I should offer them a later appointment. It's tools in this CARES manual also are for who should get a reproductive health exam. Everyone with a cervix. And then on each page of the manual, there's a QR code that actually gives you more information for being able to realize what you want from your doctor and what you want from that reproductive health exam, like a screening for abuse and neglect. And listen, we are learning about more and more tools. Most recently, we participated in a webinar that talked about the HITS tool, which is a hurts, insult, threaten, scream tool for looking for abuse. And I think that language is a lot more accessible to our patients than some of the other abuse screening tools. The tool that we included on our CARES manual included if our patients don't have access to the tools that they need just to get through everyday life. So when our patients, caregivers, moms, dads included, don't bring their communication device, we're totally creating a barrier for them, and that's just neglect. Again, not to the level that we would need to report them, but certainly we just need people to recognize when they don't have access to those tools, that it's a huge barrier. But even more importantly, if we take away those tools in their living environments where they can't actually navigate their own homes, that's a huge barrier and a huge alert for identifying abuse. And again, we're not trying to be fear-based, we're just trying to give providers and patients and caregivers tools to identify where there might be risk. And so that's where the CARES manual give that. We do also talk about how to get a good history for talking about sexuality. And so many people would say, again, because we're using language like this is for women, our men also need advice about reproductive health care. And our 5 Ps tool in this CARES manual is a really great way that I talk to all of my patients, men and women included, about privacy, about permission and consent, about pleasure, about giving permission, and you can say no even if you said yes before, about prevention of STDs, and about thinking about family development and thinking about preparing for pregnancy. Men need to be included in that dialogue too. And so we use that tool for both men and women. So, and then we have a really great PAP Camp tool that includes a video that anyone can use that we hired women with disabilities to create and to teach people who look and talk like them to access really their doctor, but also these more sensitive reproductive health exams.
And there's a video in there too, right?
Yes, it's in the QR code attached to PAP Camp.
I highly recommend you scan that code and watch that video, certainly.
Yeah, and we had a couple of, one thing that we did is making sure that our individuals had representation in some of the pictures. So part of the CARES manual is about different positioning that can be used for individuals as they're having their pelvic exam. And we made sure that we hired a medical illustrator to put illustrations of people with disabilities so that they see themselves represented in there as well. So that's part of the CARES manual too, as well as looking at anatomy versus identity in our LGBTQ population. You know, one of the, and we're going to talk about self-swabbing in a couple minutes, but, you know, making sure that we are sensitive, that we don't out people when they come to the gynecologist office when they are transgender and they still need to have the exam done.
You know, you mentioned men earlier, Wendy, and someone asked a question. Are there any specific resources that are directed towards, you know, sexual education for males that you know about?
So there's not a lot, but there is sexuality education in, Wendy, I always forget that. I think it's Elevate.
Yes.
Elevatus.
Yeah, and we also have within that what every woman should know, there's a whole section on sexual education, and there are links to videos for individuals with IDD. And even though it's in our women's what every woman.
Oh, we just lost your audio.
Wendy, yep, we lost your audio. Not sure what happened, but those things happen sometimes. But yes, and someone else asked a question about sexual education material written specifically for people with IDD, and the Elevatus that you mentioned does have some of that information. So I would look them up. I think it's ELEVATUS or something very similar to that. So you can find it if you search that and IDD and sexual education.
And those links are in our resources as well. And so there are a lot of resources in there that are not specific to women. It's just specific to videos, pictures that are more in a more accessible language for people with IDD, not specifically women. And again, we know that just being a human, that humans want to develop personal relationships. Humans want to, they are sexual beings and will have sexual impulses that that we want to use the right language, and both for men and women. And there is that in there in our tool as well.
So hopefully you've had time to scan the QR code. If you didn't, you can download these slides in the handout section and scan it at your leisure. Let's talk about HPV. First of all, human papillomavirus. It's a virus that we know that can be a precursor to causing cervical cancer, just so we're all on the same page here. And it appears that you don't have to necessarily do that on an exam table now, huh?
So it's exciting. So I'm going to actually just define two things. So pap smears are internal exams where we collect cells on the cervix that to look for abnormalities. We can do co-testing with HPV sampling. So that means collecting the cells and also doing a culture for the virus that causes most of our cervical cancer diagnoses. So that's why we look at HPV. Our current guidelines say that we start reproductive health exams at 21, which is why your pediatrician probably doesn't talk about it as much with you. perhaps we still should, because I think that, again, our patients with intellectual and developmental disabilities need to hear about what preventative healthcare needs they have starting early and often, right? So we need to talk about these on a regular basis. So perhaps in pediatrics, we should start. We know that younger people are exposed to viruses, and they likely can clear those viruses on their own at a younger age. And so oftentimes screening for HPV before 30 is not indicated. So really our guidelines are, this is for really 30 and above, maybe 25 and above, just for doing HPV testing. We only need to do it now every 5 years if we are going to do only HPV testing. Pap smears are still important for those younger because we don't want to miss abnormal cells. The good news moment is that most people less than 30 and people in their 20s, we don't expect that they will develop cervical cancer. So I just wanted to clear up those two tests and tools. And what we see even in the world is that HPV self-collection, or with the help of your doctor in the office, but only using a swab, which is just a Q-tip. That's a little bit longer, that accesses the cells in the vaginal canal, that patients can either do themselves or clinicians can help them collect it, is, I really think, a viable opportunity. We are still looking for that other barrier that we have to get over. Does insurance cover it? So we know that some insurances do. Medicare and Medicaid by 2027, I believe, will have to cover it. So we're still a little early in this about whether insurance will cover it. It's still something that we think is important because it will empower our patients to get a less scary type of exam. We won't need to use a speculum. Patients will have a little more control over it. They can actually have one of their caregivers assist them versus having a clinician that maybe they don't have the relationship, but we hope that they do. And then I think that especially when we're talking about our patients that have some more physical challenges, like those with cerebral palsy that have some spasticity, or those with traumatic brain injury or spinal cord injuries that have more spasticity, we won't have to worry about getting into those awkward positions for using a speculum, and we can have access with the self swab.
Thank you very much for that information. You know, anything that makes testing easier and more accessible, I think, is a great thing. So as we wrap up here, let's talk about what the American College of Obstetrics and Gynecology says.
So we're really excited that some of our academic powerhouses like ACOG, the American College of OBGYNs, are really making training people about marginalized patient populations, specifically around people with disabilities, a priority. So they want to make sure that everyone who goes through an OBGYN residency are prepared to work with people with disabilities. We hope that other organizations like the American Medical Association will follow suit in making sure that we prioritize training about people with disabilities becomes a priority in each of our specialties. The AMA is overall medicine. The ADA, the American Dental Association, has made similar accommodations in their practices or in their trainings. And so I think we're hoping that we can reduce ableism, reduce discrimination against people with disabilities in our healthcare systems when people boldly emphasize addressing these barriers. And the ACOG has done that, and we're really excited that they've made that move towards prioritizing supporting people with disabilities.
Dr. Aita? Oh. No, we're still
can't hear you.
I don't know what happened.
No.
Oh well, things happen. first of all, thank you both for providing this very, very valuable and important information. There were several comments from people who talked about the high level of importance and how much this information needs to get out there for supporters, for clinicians, really for everyone. And I think, you know, you certainly made the case for that. A couple of other questions. Someone asked, can you share your thoughts on self-collection in the office versus at home? And if you have any other insights into the insurance coverage for those types of things, or Medicaid or grant funds that can cover those.
Sure. I do think that some of our women's health organizations like Planned Parenthood are going to make sure that some of these tools are more accessible. So we have some organizations. We equally try to look for grant funding so that we can have some tools available in our office, and the self-collection tool is going to be one of them, for sure. Craig, I can't remember the first question that you asked about.
It was related to insurance
home versus.
Home versus.
Part about home versus office. You know, we're using a lot of cancer screening tools in the home now, right? So we have colon cancer screening that we do in the home. I will still tell you that that's still a barrier when we're talking about caregivers in group homes versus families. I find, you know, one of the barriers for a lot of our patients who require more personal, intimate care, like changing diapers or showering and those things, there's a continuum about where the comfort level is for direct service providers for these types of more personal care. But I do think that you know, the collecting HPV sample and colon cancer screening is becoming more mainstream, and people are starting to recognize that we can do some of this care in the home where people are comfortable. Even, you know, when we have sleep apnea, we're doing them in the home now. So I think that the customer, patients, are becoming more wanting more care in their homes. And so I'm excited about that. That said, we still want patients to have continuity with their providers and have relationships so that when abnormals come up, we can talk about that too. So I think that this is going to start in the clinician's office so that we have better dialogue. And I certainly think it's, again, another way to make sure that we get better access and that it's done in the right way, and then instill confidence in the patient that they can do this in the future. So probably they'll need to repeat it every 5 years. We can do the first one in the office. We can have a relationship. We can talk about it. And then as we need subsequent screenings, then they can do it at home.
Great information again. Thank you so much, Dr. LeComte and Dr. Aita, for providing these insights, for the work that you do, for creating the manuals and everything that you do. And again, I really encourage everyone to go out there and take a look at this information. There's a handout associated with person-centered thinking practices, thinking about people first, and this certainly applies when we're talking about preventive healthcare and the needs of people as seeing them as people first, and also some general information about sexuality in people with IDD is also on that handout. I do want to let you know that if you're looking for ways to help train clinicians on how to provide good health care to people with intellectual and developmental disabilities, take a look at the curriculum in IDD healthcare. You can find more information about that on our website. We also offer person-centered thinking training and other person-centered services to help move states and organizations in ways that are always thinking about putting people first and helping to balance what people want for their lives with what they need for health and safety. And that's something that we all have to do on a daily basis. We definitely want your feedback. It's very important we use this information. One of the topics you said you wanted to hear more about was sexuality, and hence we're here today talking about it. So please fill out the surveys. There should be a link in your chat or at the end of the handout that you can download as well too. Again, a shameless plug for the IDD Health Matters podcast. We're going to have a couple of episodes with Dr. Aita and Dr. LeComte coming up very soon, and That's all we have for everyone today. Thank you again for joining us, and we hope to see you the next time on IDD Perspectives.